A very big hello to all my dear students. Let's start with cornea today. Okay, so give the heading cornea. What is the shape of the cornea? Let's begin with the shape of cornea. We will learn it as aspheric in shape. Aspheric means the curvature gradually decreases, right? Diameter, this is going to range from 11.5 mm to 12 mm. Okay, so horizontal is little longer here, right? So we learn like this. Then talking about what is the refractive index of the cornea. So we will learn it as 1.37, right? Refractive index 1.37. This is a double Q. Let's all make a Q here. Repeated question. And what is the power of the cornea? Power is 43 diopters to 45 diopters. So can you see it is responsible for major part of the total dioptric power of your eye, which is around 60 diopters, right? Then we talk about is what is the thickness. Now thickness average that is considered is 540 microns, or you can just learn it as 500 to 600 microns here, which is around 0.5 to 0.6 millimeters. And at the limbus, this is 1 millimeter. Okay, so this is 1 millimeter. Average we will consider it as most common value is 540 microns. Coming to structure of the cornea. Let's make this diagram. What are the different layers? We make a section here. Uppermost is your epithelium. Then Bowman's membrane. Then majority part of your cornea is stroma. So this is your stroma, right? Next is, of course, a recently seen layer, and this is named by the name of an Indian scientist, Dua's layer. One of the toughest layer of your cornea is Dua's layer. Then comes your Descemet's membrane, and finally endothelium. Okay, so these are the different layers of your cornea. That is your epithelium, Bowman's, stroma, Dua's layer, Descemet's membrane, and endothelium. So once we know the different layers, now let's take one by one. First we talk about is epithelial layer. So epithelial layer is not single layer, it is multi-layered, consisting of, this is the basement membrane on which you will have a single layer of columnar cells. First, these single layer of columnar cells are called basal cells. These are columnar. Then comes 2-3 layers of wing cells. And the uppermost layer, again 2-layered, is stratified squamous epithelium. I hope you are making the diagram along with me. This stratified squamous epithelium is non-keratinized, just as we learned for conjunctiva. So you will write here non-keratinized stratified squamous epithelium. Or if you put a Q here also, they have asked you this as well. And what is above that are microvilli or microplici. You can say plici or microvilli. So microvilli or microplici. P-L-I-C-A-E. Okay. Now what is the role of microvilli? So, microvilli is increasing the surface area, common sense. And what else it is doing? It is helping to adhere the tear film to the cornea. Which is the lowermost layer of the tear film, which is just above the cornea, is your mucin layer, right? So microvilli will increase the surface area, and secondly you will write it is also helping in attachment of tear film to the cornea. Okay. Now another interesting thing is that these basal cells are attached to the basement membrane with the help of, this attachment is called hemidesmosomes. Okay, this is what is called hemidesmosome. Now, what applied you have to learn here is that during all this, in all the conditions of corneal dystrophy, where there is recurrent erosion, the main problem lies here in hemidesmosomes. Okay, so we can note down in corneal dystrophies, the problem lies in, so there is a defective attachment, or the main problem is in the hemidesmosomes. Okay, so and this is the reason for, so we are going to learn about corneal dystrophies, but just one line here, and this is the reason of recurrent erosion. And if you have any erosion which is traumatic, what is just below this basement membrane, which layer? Of course, I hope you all have understood. After this will come your Bowman's membrane. So generally a traumatic erosion is between basement and Bowman's membrane. They won't ask you this at your level, let's forget it. This much is enough. So that was about your epithelial layer. Next we talk about Bowman's membrane. So actually Bowman's membrane is part of stroma only. Okay. So this is an acellular membrane. It is not a basement membrane, just remember, and it is part of stroma, and therefore very important thing, it will not regenerate. Okay, this is important, does not regenerate. Okay, then we talk about is after this, these are some points about Bowman's membrane. Then we talk about next is your, what is next after Bowman's was stroma. So if you talk about the stroma, stroma mainly consists of lamellae. So there are those collagen lamellae, they are around 200 to 300 lamellae. Okay, and it is nothing but collagen fibrils. What is which type of collagen? This we will learn here is type 1 collagen. Along with this collagen fibrils, what else are getting here is ground substance. And what ground substance? What is it composed of? This is very, very important. We'll be discussing it further as well. This is mainly glycosaminoglycans or proteoglycans. So this glycosaminoglycans, mainly two names which are very important for you, recently asked in your exam, keratin sulfate and chondroitin sulfate. Keratin sulfate and chondroitin sulfate. Okay. What else you will get? Keratocytes, which are fibroblasts. So the third component, one is collagen fibrils, ground substance, and keratocytes or fibroblasts. Fibroblasts, these are also called keratocytes. This is a composition of your stroma. Right? Okay, and 90% of the thickness is, for due to stroma. So this is the thickest layer of your cornea. And just then after that comes your Dua's layer. So few lines about Dua's layer. Again, this is an acellular layer. Okay, and it is one of the toughest layer. Two important points: strongest layer, and it is acellular. I don't want you to learn the collagen details of every layer. Just remember acellular, and this is one of the strongest layers. Okay, what comes next is Descemet's membrane. So, give the heading Descemet's membrane. Descemet's membrane. So, all of you, Descemet's membrane is actually banded and non-banded. The banded part is already laid down in uterus. And this non-banded part is actually being secreted by your endothelial cells. This is formed by endothelial cells. Right? And this is the part which will regenerate. The banded part will regenerate. Keep this in mind. Right? And of course, if you have learned your glaucoma chapter with me, any stretching causes break to the inelastic membrane. So no elastic tissue, and this is the reason Descemet's membrane breaks and leads to stria. So keep that applied in mind. This is the cause of Hab stria in ophthalmos and Vogue stria we are going to learn in this chapter, keratoconus. So why are you getting it? Because of the break of Descemet's membrane, right? And of course, let's also not forget on gonioscopy, this Descemet's membrane is what you call Schwalbe's line. This is what is Schwalbe's line, right? So, anti-MO structure, that is your Schwalbe's line. So, that was about your Descemet's membrane. Then we are left with endothelium. Very important layer again. Endothelium is a single, it's a mono layer of polygonal cells. Okay? So it is a single layer of polygonal cells. Now this single layer of polygonal cells, right? Again very important point, does not regenerate. Make a Q there. Does not. So if you have both options given, Bowman's membrane, stroma, endothelium, of course all three do not regenerate, but the first answer will always be for the endothelium if you are stuck. Okay? So does not regenerate. Right? So which are the layers which regenerate? One is your epithelium, which is continuously being renewed from the limbal stem cells. You remember that? And second, of course, is the part of the Descemet's membrane, right? The non-banded part of Descemet's membrane. Okay. So that was about endothelium. And what is the main role of endothelium? To keep your cornea in a dehydrated state. We are going to talk about it further. But remember, it does not regenerate. And since it is very important for maintaining the dehydration state, therefore the number of endothelial cells is very critical for the health of cornea. Right? Okay. So once we know this much and about the different layers of the cornea, let us also remember and learn one more interesting point, that cornea is your most densely innervated tissue in the body. It is cornea, right? So where is the nerve supply from? Sensory supply, that is trigeminal. So from the ophthalmic division of trigeminal, the next branch that we follow is nasociliary nerve. And this nasociliary nerve gives rise to long posterior ciliary nerve. And this is supplying the cornea. It forms plexus at three levels. Either it is intraepithelial plexus, okay, or it can be your subepithelial, just below the epithelium, or it could be stromal, right? So the plexus will be formed at any of the three levels. Are formed in at all these three, not any of the three, all these three levels. So that is why it is densely innervated. Now what is the applied you have to keep in mind here, and that is about what is neurotrophic. This is important as an exam. Neurotrophic keratitis, and another term is what is neuroparalytic keratitis. You just learned with me that mainly the fifth nerve is supplying the cornea, right? So when the fifth nerve is gone, what you are going to get due to fifth nerve lesion, if the fifth nerve is gone, we get neurotrophic keratitis. Why? Because the fifth nerve is, when it is intact, when it is healthy, it is releasing neuropeptides, which is very important for the health of the epithelial lining of cornea. So once the fifth nerve supply is gone, no growth factors, no neuropeptides, and therefore compromises with the health of the epithelium. Okay, this is the reason that you start getting keratitis, right? So if they ask you which nerve involved, you should answer fifth nerve. But if they ask you about neuroparalytic, it is the seventh nerve palsy. Why? Because seventh nerve palsy or facial nerve palsy will cause what? It supplies which muscle? Orbicularis oculi, which closes your eye. So when the orbicularis oculi is affected, eyes cannot close, the lids cannot close. What do you get? What is that inability to close the eye known as? Leg of thalamus. And because of that leg of thalamus, what am I going to get here is exposure keratitis. This is the reason of exposure keratitis. Okay, so this is what is neuroparalytic keratitis, and this one is your neurotrophic keratitis. We will keep this in mind, right? Okay, come to little bit more discussion on physiology here now. This was all anatomy. So if you talk about the physiology, Of course, we all know that mainly, okay, if I ask you, is it cornea is again, of course, avascular, except the limbal blood vessels. Okay, is it dehydrated? Yes, it is dehydrated. What else? What is the primary metabolism? Again, when I'm asking primary, I mean both are there, which is primary. So, primary metabolism, again, your answer this time should be aerobic, not anaerobic, okay? Aerobic metabolism is the primary. In lens, it was anaerobic. Here, you should answer aerobic. Okay. From where does it get the nutrition if it is avascular? We have learnt it, nutrition from aqueous humor. From aqueous humor. Now, coming to a very important point, here is about dehydrated state. Let's just understand and ponder this. The whole cornea is surrounded only with water and still it maintains its dehydrated state. How? So, this is because this endothelial cell is not allowing the water to get inside the cornea. That is called the barrier function of the cornea. So, one is your barrier function. And apart from that, will it still be possible that no water enters? No. Some water will still go inside. So, what is the next important thing it is doing? It is pumping the water back into the aqueous. Whatever water goes inside is pumped back through sodium potassium ATPase pump. Right? It is pumped back to sodium potassium ATPase pump. And this is what is called pump function of endothelium. So, it is mainly both, but primarily pump function and then barrier function, which helps to keep the cornea in a dehydrated state. So, that means endothelium is a very, very important part of your cornea, isn't it? Whenever it is not feeling well, what will happen to cornea? Edema, hydration. Keep that in mind. Whenever endothelium is not feeling well, there is going to be hydration. So, the number of endothelial cells is critical and important. So, next we will learn that a normal number of in adult it is 2500 to 3000 cells. Per millimeter it is square, not cube. Please remember that. And for children, this is 3500 to 4500. Somewhere it is more as well, but let's learn this. Per millimeter square. Okay, so this is your normal number. Now let's see what happens. This is the cornea. We just made a section. We're making it again. This is epithelium, Bowman, stroma, and this becomes your endothelium. Now suppose I've shown you here that this endothelium cell is damaged. I've just created a gap here. So what happens when endothelium is damaged? It doesn't regenerate. We have just learned it. So what happens is that adjacent endothelium will change its shape, enlarge itself and cover the space. What is so big about it? The terms. You should know changing of shape is what is called pleomorphism and enlarging is what is called polymegathism. Therefore, whenever there is a damage, the cornea undergoes what? Pleomorphism and polymegathism. So this is just a morphological compensation, but let's common sense. Whenever damage is there, the rest of the endothelium cell is going to take care of the pump function, so that cornea is never hydrated. So some endothelium is damaged, there is a compensation. More damage, still compensation. We don't want cornea to get hydrated because that will hamper the vision. And of course, there has to be a limit. And what is that limit is your exam question. So this limit is if now only less than 500 cells per millimeter square is left. These are too less endothelial cells to manage the dehydrated state and therefore no compensation. When I say no compensation means what? Edema. First it is going to be some stromal edema. Now suppose the situation aggravates, more hydration. Now there is epithelium edema, more hydration. Then there are blister-like elevation on the epithelium layer. It's a very painful condition. This blister-like elevation filled with fluid is what is called bullae, right? And this is what is known as bullous keratopathy. This condition is called bullous keratopathy when these bullae are formed. So what is bullae indicating? Extreme hydration. And can we now understand and say this, that bullous keratopathy will be a sign of corneal decompensation. It's a sign of corneal decompensation. Correct? Done? Good. So now you know how endothelial cell number is so very important. How do you see that? We'll come to it. Specular microscopy. We'll talk about it shortly. Also, we should talk about one more important question that came into my mind, is about when you're saying primary metabolism is aerobic. So if the primary metabolism is aerobic, so there has been an exam question out there. Please understand this. If there is anaerobic metabolism, right? So when there is too much of anaerobic metabolism in the cornea, it is going to lead to lactic acid formation. And any lactic acid, so any activation of anaerobic glycolysis, though this is in relation to one exam question that I remembered I'm mentioning, any activation of, when you're going to read the question, you'll understand, of anaerobic glycolysis will lead to lactic acid formation. Right? This is going to lead to metabolic acidosis. And any metabolic acidosis will cause inhibition of the sodium-potassium ATPase pump in the endothelial cells. So, inhibition of the sodium-potassium pump, absolutely clear now. This is going to lead to what? Edema. So, there will be corneal edema. Okay, so the primary metabolism that we should answer should be aerobic. Okay, so that was about the basic physiology, and you should have this idea. Next thing they are going to ask you is, what are the factors responsible for transparency of the cornea? So factors responsible for, I think this is a very, very important question in your MBBS also, you all must have learned it, for transparency of cornea. You don't need a mnemonic to learn this, believe me. Just common sense, we are going to think layer wise. Okay, so all of you just make this the layer of the cornea. So epithelium level, what should be the contribution for any transparency is a regular arrangement, no clumping, right? So regular arrangement of epithelial layer with no mitotic figures and no clumping, especially in the central cornea, which is responsible for your vision. Okay, so this is one thing which will contribute. What is the second? We come to stroma. In stroma, there is a regular arrangement of lamellae. Have you thought of so many lamellae, collagen? Why there is no scattering of light? Because they are so nicely, regularly and equally spaced that the distance between, so the theory and hypothesis says, no doubt, distance between two lamellae is less than half the wavelength of light. Okay, so wavelength of light. So this is Morris theory of why there is no scattering and why there is transparency in the cornea, why the light is going through and through, not disturbed and not scattered. And when you talk about this exact spacing of the corneal lamellae, this is being assisted by the ground substance. So this is being done by keratin sulfate and chondroitin sulfate. This is how this glycosaminoglycans are contributing to the transparency of the cornea. Got it? It was helping to keep the lamella in the most organized, arranged and spaced way, equal spacing. Chalo. Then what is the next factor we will think layer wise is for endothelium. We have already talked about it. Endothelium is the one, pump function and barrier function. Both pump and barrier function is keeping the cornea in a dehydrated state, and because of this there is no edema and hence transparency is maintained. What else factors? So ye ho gaya 1, this is 2. In corneal lamella you can write this keratin sulfate 3, and you can say endothelium factor is 4. Can we think of something else? Yes. Let's talk about avascularity of the cornea. This is also contributing to its transparency. What else? Did we not discuss in the glaucoma chapter that intraocular pressure should be lower than the basic stromal pressure? So IOP should be normal. normal IOP is very important. Otherwise, and it should be less than the basic stromal. Of course, it should be quite less. It should be between 10 to 21. But any pressure of more than stromal pressure can lead to epithelial edema. We have discussed this, so I'm not taking it again. So, this is, what was the stromal pressure we learned? The stromal pressure here was, in the corneal stroma, the pressure is around 53 to 55 millimeters of mercury. So, this is what is happening in acute congestive glaucoma. Acute angle closure, what is happening is that the IOP is going more than the basic stromal pressure, leading to epithelial edema. Okay. So, this was about the physiology of that, and these are the points that we are going to understand and learn in the physiology. Okay, we give the next heading as, what are the investigations related to the cornea? So, give the heading investigations related to cornea. First you will learn is keratometry. I'll show you the slide later. Write down keratometry. So, keratometry is measuring the central optic zone, right? Curvature of cornea, both vertical and horizontal, K1 and K2. But this is only for the central optical zone of 3 millimeters. Okay. So, this is your keratometry. Second we will know is what is keratoscopy, or we call it Placido's disc. So, this is very important to assess the overall surface of the cornea. Let's have a look. If you look at this Placido's disc, it is nothing but a cardboard with a colored black and white rings, and there is a central hole there. If I show it in front of your eye, the image of these rings will fall on your cornea. If your cornea is regular, I get a regular spacing of these rings. But suppose this at one part it is steeper. So, when your cornea is steeper, the rings are closer, right? So, steeper part mein closer rings, note down. And if it is a flatter cornea, we will write far apart. This is more far apart. The rings are more far apart. So, this is a qualitative, just showing the Placido disc is giving you a rough assessment whether the corneal curvature is fine or not fine, right? Now comes the next, where you can really quantitate the same thing, is through corneal topography. So, what is corneal topography? So, again these Myers are shown on the cornea, and we are able to find out which is the flatter and which is the steeper part, and you can depict it in color coding. So, the next number 3 write down is corneal topography. Again, as I said, the Myers, closer Myers are steep cornea mein, you get a closer Myers, the rings are closer, and vice versa. Name of the instrument just now, OBSCAN. So, it is all based on the principle of Placido's disc, right? Okay, now comes another question, what is pentacam? So, one is corneal topography, another term is corneal tomography, though normally we are using it as a synonymously, but there is a difference. We just saw what is corneal topography. I am writing it for you here as well. Now, number 4, corneal topography or tomography is taking, actually it is a tomography where it is taking the 3-dimensional picture or image of the cornea. Okay. So, when you say corneal tomography, I am talking about pentacam. So, what is tomography here? 3D image of cornea. What is the difference? Think yourself. Normally, you are only assessing the anterior surface of cornea, but in tomography, you will be able to assess both anterior and posterior surface. Now, why is to assess the posterior surface so important? Because initial changes in keratoconus starts from posterior surface of cornea. Therefore, this becomes more sensitive investigation. Little bit more about tomography and pentacam. So, you can note it down please, the point that I just discussed, that the 3D image is for both anterior and posterior surface of the cornea. And this is based on the Schimflug imaging. What is this Schimflug imaging? It has a rotating camera, and It rotates around the eye to take the image of anterior and posterior surface. This is what you have to know. Schimflach imaging is using a rotating camera. No more details required. Right. So first is what are the things pentacam is measuring? Penta. Okay, the name is already indicating here. First is your axial map. So we'll see the maps also. So when you talk about the axial map, of course we are assessing the curvature in the whole cornea, and we are depicting it into the color coding system. That means the steeper part is always depicted with warmer colors. So steeper part will be depicted. Warm colors means, I hope you have understood this. So green is taken as neutral, anything towards the red is warm, and before is cool. So we are talking about, so towards red or red. This is the steeper part. Whereas flatter parts are depicted by cooler colors. So it looks complicated, but it's very simple. Okay. So that means around blue. So this way we get an idea about the curvature of the cornea and about where the astigmatism is, where it is regular or where it is irregular. The second thing that it will measure is your pachymetry reading. It gives a pachymetry. What is pachymetry? It has been an exam question as well. This is thickness of the cornea. Okay. So common sense, wherever there is a steeper cornea, thickness will be lesser. That means thinner cornea will have warmer colors, the cornea warmer colors, that means red, and thicker cornea will have cooler colors towards blue. Then we talk about next, what it tells you is anterior elevation map and posterior elevation map. What is anterior elevation map is on the anterior surface. So again we are taking the curvature only. But this time we are comparing it with a baseline. And what is that baseline? Best fit sphere. So what is the best fit sphere? Above the best fit sphere is, when it is above, it is depicted as warmer colors, and when it is below, it is depicted as cooler colors. Okay? So what is the curvature? Above this is more, is it more or is it less? This is how the color coding is done. And this can be done for the posterior surface also. That is your posterior elevation map. So posterior elevation map, again we are seeing the same thing. That is above the best fit sphere and below the best fit sphere. So the baseline is our best fit sphere. Okay. So, and what else? Penta. So what is the next fifth finding? It also tells you the anterior chamber depth. Right. So when you talk about the uses of pentacam, of course, first very important is in keratoconus, diagnosis, management, assessment, screening and so on. Secondly, it can assess preoperatively whether this patient is actually suitable for a corneal refractive surgery or it is not. Okay. So we are also measuring we are also assessing for the pre-op assessment. You can write down, it is helpful for the pre-op assessment of patients undergoing corneal refractive surgery. So anybody wants to get a LASIK done should first get a pentacam to understand and assess the case. Then we will know whether this patient can undergo this surgery or not. What can be some other uses? Now there's some other uses. So the uses of pentacam has increased now. One is called pentacam HR. What is this pentacam HR? It is helping in pre-op assessment of patients for intraocular phakic IOLs. Okay. And then there can be one more, pentacam AXL will measures the axial length. Measures axial length. So when it measures axial length, it is helpful for IOL power calculations. In IOL power calculations. Right. So, and of course also in assessment of the corneal ectasia and so on. So this was about your tomography and about pentacam and its uses. We come to what is the next investigation after this? Of course, pachymetry is already done. So we'll just, to complete the list, pachymetry is measuring the thickness of cornea. What else we have to know apart from this? Any other investigation? We just talked about endothelium. This is a repeated question of your exam. What is specular microscopy? So now you know what is specular microscopy. You will say this is to measure the specular microscopy is to see the endothelial cells, to examine endo. So we are doing this in a very large magnification. Okay, so we see the endothelial cells in a very high magnification. We are concerned both about its number per millimeter square and also about its morphology. How many cells have undergone pleomorphism or polymorphism? How much healthy it is? Is there any corneal guttati? What is corneal guttati? So one additional applied we are learning here. Corneal guttati is nothing. You see some empty spaces on specular microscopy. These are affected cells and seen in Fuchs endothelial dystrophy. These are collagenous protuberances, Fuchs endothelial dystrophy. It's a feature of this condition. And we generally on specular microscopy, it is visible as empty spaces. Okay, so that is one thing. I'll just show you the slide. And next, after this, another investigation would be corneal sensation. How do we see? Majority of the time by the cotton. Touch the wisp of the cotton at the side, not in the center, of course, otherwise anybody can blink like this only. So when you bring that from the side and touch it on the cornea, you see how brisk is the blink reflex. Is it normal or is it delayed? This is going to give us the idea about the corneal sensation. But what is the instrument? That is called aesthesiometer. Okay, so aesthesiometer is nothing but it has a long filament and you are just going to decrease. So it's all 60 mm and then you decrease it by 0.5 centimeters and keep touching and seeing at what length of the filament the patient can show the blink reflex. If the shorter length it shows, that means sensation is less. If at a longer length it is showing, then it is okay, right? So this is your aesthesiometer. So the aesthesiometer has to be recognized. We will show you just now. Make a cue there. And lastly, microbiological investigations. So microbiological investigations, that means staining and culture. Okay. So very quickly, what were the investigations? Keratometry, keratoscopy through Placido's disc, corneal topography, again based on Placido's disc, or corneal topography or tomography where you get a 3D image, that is pentacam. Very important investigation. Then what next? Pachymetry, specular microscopy and aesthesiometry or aesthesiometer, how you see the corneal sensation, and lastly microbiological investigations. Okay? So this is what we just discussed. Let's have a look at the slides. Okay, so I think we have already seen this much. We come to the next. So this is how a pentacam looks like. Okay. So this is your axial map. This is the pachymetry reading. It is showing on color coding will show, and this is actually a normal finding where you are seeing the green part and how it slowly becomes more flatter towards the blue part, right? So, and then this is the anti-elevation map and posterior-elevation map. So this is a normal finding in a normal patient. One more thing, whether it is actually accurate or not is depicted by QS value, which is quality sensitive. So quality sensitive value should be ideally more than 95 for us to rely on the map. Okay. Then look at this one. So this is what is, you can see the red out here, right? Which is not normal. This is red means steeper. This part has become steeper here. This is what is your keratoconus. When I do the pentagram here, this is what I am seeing in a pentagram. It's all steeper at the center. Here also, can you see? The red means thinner, thin cornea. It is steeper and thinner at the center. This is a case of keratoconus. And what is this? This is a regular astigmatism where you can see, just recognize, can you see this? This is what is called bow tie appearance. Can you see the shape? It is like a bow tie. So it's a bow tie along a single meridian is indicating a regular astigmatism in that meridian. And now what you are looking at? This is a pachymeter. Okay, so we should know what is a pachymeter. This is to see the thickness of the cornea. This is your corneal specular microscopy. So this is what is specular microscopy. Right? So when you're looking at the endothelial cells in a magnification, this is how these cells look like, polygonal single layered cells. And if the empty spaces, what did I tell you? This is a feature of Huth's endothelial dystrophy. We call it corneal guttating. This is normal that you're looking at. So you're going to see if there is any polymorphism, pleomorphism, what is the number of cells and so on. And this is the aesthesiometer we are talking about. Can you see the filament here? So keep decreasing the length and keep touching and assessing at what length the patient responds. At what length of this filament the patient responds. So you can actually quantify the corneal sensation through this instrument. Okay, what we were left with were these slides, but I think this is absolutely clear. This is epithelium, and then comes your Bowman's membrane. This is the Bowman's membrane, this line. This is stroma. This line is Dua's layer. This is your Descemet's membrane, and this is your endothelium. Okay, we have discussed it in detail, and you can even get a histology picture like this. So you should be able to demarcate the different layers. This is your endothelium, the Descemet's membrane is seen here, right? This is all stroma, Bowman's and epithelium. This is what you can actually make out in histology. Okay, so once we know this, now we come to the next thing is what is an ulcer? So all of you, I think everybody knows what is an ulcer. What is an ulcer? It is breach in the epithelium. So breach in epithelium is ulcer. So when you say breach in epithelium, is it only breach? Along with that, there is some infiltration. Along with that, there can be necrosis. This is what is ulcer. So if you look here, if this is suppose the cornea and the epithelial layer, I am saying any interruption of this epithelial layer, this one is ulcer. Correct? So the maximum infections in the cornea will occur when there is ulcer formation. But there are few organisms which can penetrate intact epithelium. Few organisms that can penetrate intact epithelium. This is asked in the exam. Okay, let's make a Q, nice Q and learn it. Give the heading, organisms that can penetrate intact epithelium. So what are the organisms? We will learn this time with the mnemonic NN, LDH. And last May, the recent edition S. So NN, LDH, S. What is NN? Is simple, both the Neisseриas, you'll never forget it. So Neisseria gonorrhea and Neisseria meningitis. L stands for your listeria. Then D is diphtheria. H is Haemophilus. S we will learn as Shigella. S is Shigella. Okay, easy to learn now. So these are the organisms which can penetrate intact epithelium, and it is asked in your exam. Please learn it. Okay, so what is keratitis then? Inflammation of the cornea, where you're getting an ulcer formation, necrosis, infiltration, and neovascularization. What is neovascularization or vascularization of cornea called? Pannus, isn't it? So any superficial vascularization and some degenerative change subepithelium. So this superficial vascularization is what is called pannus. So what is keratitis? If I ask you, you will say it is inflammation of the cornea, isn't it? Inflammation of cornea, where you can get ulcer formation, where there can be presence of pannus. Okay, so once this is all clear to you, we talk about keratitis is inflammation. So any type of ulcer, we are going to read all the types, different types, bacterial, fungal, viral. This is what we are going to next discuss. So I'm going to make the discussion interesting, so don't bother. What is very, very simply that you have to understand here is that whatever may be the type, whatever may be the cause, there are few presentations which are common to all. So we are going to learn it as 5 fingers or 6 fingers here. Any keratitis, bacterial, viral, fungal. So you will always get pain, redness. Which redness, all of you? It has to be ciliary congestion. We have discussed this in the conjunctiva chapter also. It is ciliary congestion, means when the blood vessels are around the limbus, they are deeper vessels and they are straight. Then photophobia, which is intolerance to light, we all know this. Or kya? Blepharospasm, closure of eyes due to photophobia. Discharge again depends on etiology. And lastly, blurring of vision, that is blurred vision. Easy to learn. So pain, redness, photophobia, blepharospasm, discharge, blurred vision. Every keratitis, majority of the keratitis is going to present like this, right? Okay. And why it is all happening? Either there's an ulcer formation which has led to all these infections, or the immunity is less, immunocompromised patients, common sense. So keep in mind these can be the two factors which will affect the cornea. We already have once for all learned how a patient of keratitis is going to present. Bacterial, first of all, the first question that they are going to ask you is what is the most common etiology? So give the heading etiology. Most common cause, we will answer Staph aureus. Simple, Staph aureus. Next question, if they ask you most common bacteria causing keratitis in India, then our answer is Staph epidermidis. Okay, so this is the recent finding that then we should answer Staph epidermidis. Another thing, what is the most common bacteria after refractive surgery or after LASIK surgery? So, after LASIK surgery, the most common infection after this refractive surgery can be due to atypical mycobacterium. So, write down after refractive surgery, we will answer atypical mycobacterium. If you want to know the name, atypical mycobacterium, M. kelloni. Forget it, Mycobacterium kelloni. Next we talk about is other causes could be the streptococcus, right? Apart from Staph aureus, Staph epidermidis. So we will learn the next cause will be streptococcus. Streptococcus pneumoniae, that is also called pneumococcus, right? This is also called pneumococcus or streptococcus pyogenes. Both can be a cause of bacterial keratitis. Now two more questions here, all of you pay attention for regarding pneumococcus. So pneumococcus or streptococcus pneumoniae, the ulcer is seen in a serpentine manner, traveling in a serpentine manner, right? This is called ulcus serpens. This is your ulcus serpens, when the ulcer is progressing in a serpentine manner. And the ulcer is also called, this is also a Q inverted commas, hypopion corneal ulcer. We will say it is also called hypopion corneal ulcer. Right, all of you? So that was about a few questions on etiology. And yes, one more very recently asked question is which bacterial infection resembles a fungal keratitis? And the answer will be nocardia. Okay, so nocardia presentation is again a dry rough ulcer just like a fungal keratitis. So it resembles fungal keratitis. The look is again the ulcer is dry and rough. You can note down ulcer is dry and rough, right? So after etiology comes the clinical features, and what are the presenting feature? The same 5-6 features you have learned for keratitis. We will note it down. On examination, what you get? On examination, let's make a diagram. So what you see here is a fluorescein stain positive ulcer, number 1. So we all know that fluorescein stains the denuded epithelium. So you will get a fluorescein stain positive ulcer, number 1. Apart from that, what you are getting? You may get pus cells in the anterior chamber which we call hypopion. All of you note down another cue here. This is a sterile hypopion. Make a cue, sterile hypopion. No bacteria, only pus cells, therefore you call sterile hypopion. Now whenever there is an ulcer area, of course, what will be the effect on the other layers? So in the epithelium, it is a denuded epithelium. Apart from that, you may get stromal edema or stromal edema around it, and you may even get Descemet's membrane folds around it, right? If you want to note it in a section, you can even draw like this, that if this is an ulcer here, denuded epithelium, along with this ulcer area, we are getting stromal edema, and we are may also get Descemet's membrane folds. And of course, any ulcer can be associated with, any keratitis can be also associated with uveitis, as you can see here. So you may also get KPs. You can note down, we may get keratic precipitates due to anterior uveitis. You can note down due to anterior uveitis. Right? So these are some of the findings of a bacterial ulcer. Now the progress or course of any ulcer, we can just understand this way. There are broadly 3 types of ulcers. So if we look at it, it can be either a perforating corneal ulcer, or it could be presenting as a localized. When you say localized, it simply means that when I am treating it, it is healing. Please keep writing with me. If it is healing, it is going to lead to opacity. That is nothing but scarring. So that scarring is called corneal opacity. Right? So this is one thing. This is a localized type. I try to treat it and it has responded. This is a localized ulcer. But suppose there is a lot of thinning, especially we are talking about an infection by Pseudomonas. This was a question. Which organism can cause corneal perforation in 48 hours? This is your cue. So what happens? It is releasing toxins or exotoxins which have collagenolytic effect. Okay. So these toxins have exotoxins released by the Pseudomonas have collagenolytic effect. This will lead to perforation. Right? So anyway, this was about Pseudomonas, but any ulcer can cause corneal thinning and may lead to perforation. Pseudomonas tends to do it more, right? So whenever there is a thinning and there is perforation, what will happen? When there is a thinning and perforation, so what will happen if there is a perforation? Is it going to remain open? Of course, there is going to be leakage of the aqueous, but it is not going to remain open. Iris from behind will come and seal it. And when iris sees this perforation, this is what is called leukoma adherens. Okay, so write it down here that iris seals the perforation, and this whole thing is what is called leukoma adherens. Right? Leukoma is opacity, adherence means the iris is adhered to it to block it. So this is the exam question. Leukoma adherens is a feature of, you will answer, perforating corneal ulcer. Come to the third type. The third type is your sloughing corneal ulcer. Now what is sloughing corneal ulcer? A very virulent organism is actually infecting the cornea. So when a very virulent organism is infecting the cornea, this is going to eat it up, cause necrosis of the cornea. Okay. So again, it doesn't mean that everything is open now. No. So it is replaced, continuously being replaced by inflammatory tissue. So write it down here. This is infection by a very virulent organism, or infection is very virulent, and this is going to lead to sloughing and necrosis, and this sloughing is simultaneously replaced by inflammatory exudates. So replaced by inflammatory exudates, and this is going to lead to what we call pseudocornea. We will not forget this also, it's exam key question. So pseudocornea means it's not the actual, the 5-6 layer that you have learned. This time it is mainly inflammatory exudate which is forming the cornea. And what is this? Pseudocornea is the cause of, you will answer, anterior staphyloma. It can complicate into, we have learnt in sclera, that this can complicate as anterior staphyloma. Okay, so one complication which is the most common cause of anterior staphyloma is pseudocornea. So these are the three types of ulcer we will keep in mind. Right, then we talk about the investigations in bacterial keratitis. Of course, microbiological is the prime. So what you can do, you can take the sample by either by corneal scraping, or it could be just a conjunctival swab as well along with the scraping, but of course scraping has to be done. How do you do the scraping? Don't forget the name Chimera spatula. Chimera spatula. Okay? So this is the main instrument through which the scraping should be taken. You can also take through 21 or 26 gauge needle, right? But generally with this spatula, or also conjunctival swab, or you may take the sample from contact lens cases. So whatever it is, we generally go for the microbiological investigation, and that is your staining and culture, right? So investigation prime is staining and culture. Staining, how do you stain? Everybody remembers gram stain, Giemsa stain. So gram stain, positive or negative. Second, we can go for a Giemsa stain. And of course, for the pair of bacteria like Mycobacterium or Nocardia, we have to go for acid fast stain. Okay, AFB. This is your acid fast stain. This is mainly for Mycobacterium and Nocardia. Then we talk about, after this, after we know the staining options, we have to discuss the culture option. Culture, how do you culture the bacteria? Everybody knows about blood agar. And when you're heating it and causing lysis of the cells, you can get a chocolate agar, right? Apart from that, let us also learn for again Nocardia and Mycobacterium, Lowenstein, Jensen culture media. Okay, we will learn this Lowenstein, Jensen media. This is mainly again for your Mycobacterium and Nocardia. Another for anaerobes that we should know is cooked meat broth. I will not go too much into this now. This is for anaerobic like Propionobacterium acne. Okay, anaerobic bacteria. Okay, so once we know this, how we have investigated, now we talk about this treatment of bacterial keratitis. Common sense, bacterial keratitis. How will you treat it? Of course, antibiotics. So you can start either as a broad spectrum or you can go for culture sensitivity and decide on antibiotics. So monotherapy that can be started in the broad spectrum antibiotic. So that is your empirical monotherapy can be given with fluoroquinolones, right? So these are considered to be very, very effective in your corneal ulcer. Best penetration here is mainly of moxifloxacin. Okay, so we are going to prefer the newer ones like moxifloxacin with a better ocular penetration. Or other option was Gatti. I'm not very happy with Gatti. I'm more happy with moxifloxacin. I've seen patients not responding with Gatti as well, and becifloxacin is another name. But of course, not majority of the patients do respond. Then second we talk about is, of course, you can go for if it is not respond, and of course according to culture sensitivity, you can choose an antibiotic. Otherwise, suppose it is not responding in spite of culture sensitivity, we can go for duotherapy, right? So when you say duotherapy, we are using fortified eye drops. So fortified or concentrated antibiotic eye drops, and we were trying to take care of both gram positive and gram negative, therefore duo, right? So you can give a combination of cefazolin and gentamicin, both positive and negative will be taken care of, right? Gentamicin, okay? So this is one. Or instead of cefazolin, I can also use cefuroxime. So it can be cefuroxime with gentamicin. What can be the third modality next apart from that? Of course, I can give antibiotic ointment at night because at the night we need a long-term effect. Ointment at night, HS. Then you may also, if the compliance is poor, I may choose to go for subconjunctival injection. That is another option, keep in mind, right? So subconjunctival injections of antibiotics is also an option if you know that the patient is not going to take care of himself. Subconjunctival injection. Otherwise, if the topical is being given, we don't need subconjunctival. Then we talk about next is, of course, every keratitis can be associated with uveitis. We want to take care of that. We use cycloplegics and mediatics, right? And of course, I am also going to can give oral anti-inflammatories. It will relieve both inflammation and pain, right? Can I give steroids as to treat the anterior uveitis? If there is an ulcer, a big no. So we will put it in the box here. So there is a rule that if there is any infective epithelial involvement, infective epithelial ulcer, epithelial involvement means keratitis or ulcer itself means a denuded epithelium, right? So either we say epithelial involvement or we call it ulcer. If it is infective epithelial involvement, two rules that we will never break, and both are exam question. One, no steroids. Second, no pad and bandage. You should go for frequent eye drops. Never bandage the eye, otherwise infection is going to aggravate. Okay? Keep this in mind. So what else I can give apart from the oral anti-inflammatories? Number 7, you can write down vitamin A, oral vitamin A and vitamin C. It helps in healing of the ulcer. Even another thing that helps in healing of your ulcer can be lubricating eye drops. Right. So these are some of the, but generally we give this and vitamin A and vitamin C. Now, systemic antibiotics, is there any role? Should I start with some oral antibiotics? Only if there is a risk of systemic involvement, especially in case of children. This can lead to some systemic. So if there is a risk of systemic involvement, the infection is involving systemically. What are the infections? Both the Neisseria meningitis and Neisseria gonorrhea. Okay, and also your H influenzae. In these cases, I may start with oral antibiotics. Okay, so and especially in children, children are at high risk for this, and we've discussed this also in conjunctiva regarding neonatal ophthalmia. Okay, so this was about your management. Now you have done everything, and Acha, one more thing I would add here. If it is a perforating type and you can see that, okay, there's a lot of corneal thinning, though there is no perforation, immediately choose an antibiotic which has some, you can say, anticollagenase effect. So, if there is a corneal thinning which is substantial, then I should go for either tetracycline or doxycycline oral. I can start. Why I will start this or I will start doxy? You will say this is your has anticollagenase effect. Okay, now you have done everything, all the measures taken, whatever we have discussed here, all the antibiotics and drugs have been given. The ulcer is still not healing. What will you do next? So our next heading is management of a non-healing ulcer. So management of non-healing ulcer. If this is the case, the first thing I can do to help healing is debridement. What is debridement? I am removing the necrotic tissue from the ulcer area. So when I remove the necrotic tissue, this is what is debridement. It helps in healing of the epithelium. Okay. Then we come to the next, of course, what will help is lubricating eye drops. Yes. What else you can do to help the healing of the ulcer? What else I can do? Chemical cauterization. Chemical cauterization. Now, what is chemical cauterization doing here? It is acting as a local antiseptic to curtail infection. Which chemical I can give? So, it acts as a local antiseptic. That is the role of putting locally doing the chemical cauterization. So, which chemical we can use is your exam question. Trichloroacetic acid you will answer first. Second option can be carbolic acid. Okay, so TCA क्या है? Trichloroacetic acid. Trichloroacetic acid. Second option can be carbolic acid. Okay, what else I can do to manage this non-healing ulcer? I have to promote epithelialization. Apart from these things, we can also go for bandage contact lens. Okay, so bandage BCL short form you should know. So bandage contact lens is going to improve the comfort of the patient. And sometimes when there is too much of thinning, then it will act to even as a sealing a very small perforation can help to seal it also. But anyway, we will learn that bandage contact lens is another way of it. What is a bandage contact lens as such? So contact lenses broadly, theoretically you can say it is semi-soft, soft and hard. Okay? But hard is now not used. So broadly we learn as these contact lens can be either soft or semi-soft. So what is bandage contact lens? It is high water content soft contact lens. So it's a high water content soft contact lens. Right? So soft contact lens may be low, medium, high water content. So generally the high is better. Why? More the water content, better is the oxygen transferability through the lens. So your corneal health is better. Anyway, this is a different topic altogether. We will discuss later. And what can be some surgical means in helping the healing process? If nothing is helping, we can go for some surgical means like you can go for amniotic membrane grafting, right, to help the ulcer heal. Second, you can go for buccal mucous membrane. So, buccal mucous membrane grafting. Right? Or third, what you can go for is in severe cases with a poor visual prognosis, we can go for if visual prognosis is poor and we just need ulcer healing of the ulcer, it's a persistent defect, it is not being healed. If this is the situation, persistent defect, we can go for Gunderson's conjunctival flapping, right? So in Gunderson's conjunctival flapping, what we are doing, we are covering the whole of the corneal area with the, so if this is the area of the ulcer, but we are covering the whole thing with the conjunctiva. So you're putting the conjunctival flap over the cornea, right? So covering it with the conjunctiva. This is your done to again in extreme cases for helping to heal the ulcer. Okay, so that was about management of non-healing ulcer, but one thing needs more mention is about your how will you manage impending perforation. This is again important. So I have a patient in my OPD, there is a lot of corneal thinning in this patient, it feels anytime it can perforate. What are the things I should do that it shouldn't? Immediately I should start with some anti-glaucoma, even if IOP is normal, to decrease the IOP further. This will help to prevent any perforation, number one. Secondly, what I can go for? At the area of thinning, or sometimes even when there is actual perforation, how do you manage it? You put cyanoacrylate glue. Okay, so this cyanoacrylate glue, it can be considered as sterile Fevikwik, that's also cyanoacrylate, right? But this one is sterile. So this is generally effective in treating also the corneal perforation which are less than 2 millimeters. So at less than 2 millimeters defect, we can actually fill with this cyanoacrylate glue. But if the perforation is more than that, at present we are talking about impending. Even then we are putting a cyanoacrylate to prevent perforation. But suppose you already come, a patient has perforation. If it is less than 2, we can manage again with cyanoacrylate. But if it is more than 2 millimeter in size, then you have to go for therapeutic keratoplasty. Okay, therapeutic keratoplasty means what? Replacing the cornea with a healthy cornea. Therapeutic means what? I am doing it to help out in the healing of the ulcer. So we'll talk about keratoplasty, it will be more clear to you. So that was about how you manage the impending perforation. Another thing that I can do apart from this, let's not forget the role of bandage contact lens, which can also help in healing and causing tamponade at that point of corneal thinning. Right? So this is your management of impending perforation and how we can help in healing the non-healing ulcers. Okay. Next we talk about, let's have a look at the few slides. So this one is showing you the pannus, that is the neovascularization, right, in the superficial cornea. Here is your corneal ulcer. This is a bacterial corneal ulcer with a lot of congestion, right. This one again I want to show you here is hypopyon. Along with, can you see such a big ulcer at the central cornea? This is the corneal ulcer, which is a bacterial with a hypopyon, that is a pus cells in the anterior chamber. As we have learned earlier, this is actually a sterile hypopyon. It's a sterile hypopyon. And what is this ulcer? Look at this one. This has a more rough look, isn't it? So when the ulcer has a dry, rough look, it is a fungal ulcer we are talking about. So dry, rough ulcer. Fungal ulcer, we can say it is keratomycosis. So our next heading will be fungal keratitis, also called keratomycosis. Which is the fungus which infects the cornea? So broadly, first of all, you all should have an idea. Two types of fungal infection. One group is called yeasts, right? So name that you have to know here, most common is, of course, Candida albicans. This infection is more in the temperate regions and colder regions. And the second, of course, is your filamentous fungi. Filamentous fungi, this is actually septate and non-pigmented. This septate fungi infects the cornea in tropical countries, and main two names that you have to know is Aspergillus and Fusarium. So all of you, once you know these two group of fungi, and we are not talking in too much detail, but the things that we are supposed to know at this point. So they will ask you the first question, keratomycosis, it's a very important topic. Which is the most common fungus infecting cornea? Which is the most common fungus infecting cornea? It will be Aspergillus, you should know the full name, fumigatus. It is Aspergillus fumigatus, right? Okay. Then they will ask you, if this option is not given, what is the next best option I will mark? Fusarium. So these are the two filamentous fungi which tend to be causing infection in the cornea. Let us talk a little bit more here. What is the most common infection, fungal infection for lids? Now our answer will be Candida albicans. And if I ask you for what is the most common fungal infection for endophthalmitis, what you will answer? Endophthalmitis. Again our answer is, so what is the most common? Again your answer is Candida. Okay, and if you are asked most common cause of orbital cellulitis here, orbital cellulitis, mucormycosis. You all know mucormycosis? It has been an important topic for you now. Lot of cases of mucormycosis after COVID. Why? Because the steroids were just used thoughtlessly, right? So I hope you all know black fungus doesn't mean that the fungus is black. It is causing necrosis in the tissue and therefore we call it black fungus. We'll talk about it in the Orbit chapter also. So just know that the most common cause, fungal cause of orbital cellulitis, we will answer mucormycosis. Okay, so once we know which is the most common fungus infecting the cornea, and of course the infection, as we have learnt, is generally, this is a repeated question. Why will you get a fungal keratitis? Trauma by a vegetative matter. Please remember, trauma by vegetative matter. Like getting hurt by a leaf or a twig. That is why it is more common in agricultural groups, right? Okay. So please don't forget organic matter or vegetative matter. Otherwise, of course, any cause of low immunity can be a predisposition towards fungal infection. This we all know, immunocompromised patients. Right. So once we know this, the next important question, so we have started with Q's only here. Compared to bacterial keratitis, signs are more or symptoms are more? This is an important question asked. So you will say signs are more than symptoms. We are comparing with what? Be clear, bacterial keratitis. What do we mean by when we say this? Suppose a patient is entering my OPD, he is not shouting out of pain. He comes and sits in front of my slit lamp and I observe a very big, examine him and I see a very big ulcer on his cornea. It cannot be bacterial, it has to be fungal. Right? Bacterial, even this much of the ulcer and the patient is shouting out of pain. Okay? So this is what we mean by that the signs are more than symptoms. Correct? Okay, so once we know these important points, how will this patient present? Life is simple. Again, those 5 features, this is what pain, redness, photophobia, blepharospasm, discharge, blurred vision, everything will be there. But of course, compared to signs, the symptoms are less. Right? Okay. Then we come to on examination. What do you get? Let's draw. That's what we do when we learn on examination. My style, you will draw it. First, you will draw this and write here that you get a dry, rough ulcer. First important point. Which was the bacteria which had the same appearance? We just learned nocardia. Okay. Then, second, of course, it's factual. You have to learn it. It has projecting ends. These are hyphae. Next important point. Third point, the ulcer, the hypopion here is unsterile. What do you mean by this? Fungi can penetrate the whole cornea and enter into the anterior chamber. That is why we are saying unsterile hypopion. Got it? So what do you mean by unsterile? Actually, don't get confused with these are the bacteria which can penetrate the intact bacteria which can penetrate intact epithelium. We are not talking about the whole cornea. Just penetrating the intact epithelium and infecting the cornea is one thing, and going into the anterior chamber is another thing. So what is fungi doing? It can go into the anterior chamber and therefore the hypopion is unsterile. We can see the fungi here. I think it's clear now. Then of course a double Q. This is also Q. I hope you know this. And then comes a double Q, and that is your satellite nodules. What are these? Main lesion ke alawa, apart from the main lesions, you are getting satellite lesions or nodules. These are lesions away from the main ulcer. Right? So this is why? Because it is not only infective in nature, these satellite nodules are both infective and also there is an immune response. What else I can see? I can see a Wesley ring, immune ring called Weasley ring. So again, the immune cells are accumulating and forming a ring out there around the ulcer area or somewhere on the cornea. So this is what is called Weasley's ring. Now, what is this exactly? Is it only a feature of fungal? No. Please remember, it's an immune ring host response towards the infection, correct? So it can be seen in fungal, in few bacterial also, and in viral also. But if they ask you to choose one, we will always give priority to fungal keratitis, right? So these are the points to remember for your fungal keratitis. What are the findings? So these are the on-examination findings. What can be some other features it can lead to? Of course, we all know every keratitis can be associated with uveitis. So this patient can also present, a fungal keratitis patient may also have uveitis. That means he may present with KPs here, right? And pressures because of inflammation and blockage may be high. So intraocular pressure may be high, okay? Very severe cases, I don't want to go into that, that can lead to scleritis, that's not needed at a level. This much is enough. So these are the findings of the fungal keratitis. Now we talk about next is your investigation. Of course, one is microbiological. We are doing a corneal scraping, and after scraping with the Kimura spatula, what you are going to do is your staining and culture. Second, I can directly look at the hyphae through confocal biomicroscopy. Just remember. So the second can be directly looking at the hyphae, identifying through confocal biomicroscopy. Okay? So you can identify the hyphae. See the hyphae. Okay, we have to elaborate definitely on staining and culture now. So we will divide it here as staining and culture. How do you stain a fungi? Everybody knows it is KOH smear, 10% KOH is used, right? So this 10% KOH smear, either I can see in a simple microscope, light microscope, or in a fluorescein microscope. Whatever we see the fungi, it's a quite sensitive test. Second stain that you have to know is Gomorrhe's methamine silver stain. Its full name is Grocott Gomorrhe's methamine silver stain. This is another name of the stain you have to know. What else I can use? I can go for chalcofluor white. This is also used for acanthamoeba. We have learned that, right? So chalcofluor white. और उसके अलावा ये भी लिखेंगे. What we can also add on as gram stain and giemsa stain. Gram stain and giemsa stain. Let's not complicate, this much is enough. Coming to the culture, we all know Savarot's agar, isn't it? So let's write it here. Culture media. Culture media, SDA or PDA. Either we go for Savarot's dextrose agar, right? Or you can go for potato dextrose agar. Savarot's is asked in the exam, so we will write it here. Savarot's dextrose agar. Make a Q here. This can be asked. Now, initial growth of fungi takes a lot of time, 72 hours. So, reporting should only be given after 7 days. Now, don't hurry up with the reporting of the culture here. We don't do it for bacteria, it's generally 3 days, but here we have to wait for 7 days to report. Keep this in mind. And of course, one option can also be culture is done, this is done. Another one you can notice PCR can be another option of investigation. More theoretical. What is ours is the KOH smear, what is ours is Savarot's agar. You know the microbiology part better than me now. Huh? And of course, one more thing, one option can also be, right, another one after PCR. If needed, if nothing is working, we can go for corneal biopsy as well. Okay? If scraping is not giving results, you can sometimes take a biopsy and try to test it. We come to the treatment part now. This is a repeated question and recently asked question as well. What is the drug of choice for treating a fungal keratitis? So if they ask you the drug of choice, your answer has to be natamycin. This is most effective against the filamentous fungi. Please remember. Okay? So how much percent natamycin? We will answer 5%. Initially what you do, how you give is, you start with 1 hourly in a day. 1 hourly when you give it for 2 days, and then, right, later reduce. And you have to also give 2 hourly at night. What is the ointment I can give instead of natamycin? At night can be nystatin ointment. But generally natamycin is preferred, so we are going to give 2 hourly at night also. And there can be two things. Either it is responding or it is not responding. If it is responding, if the patient is responding to the treatment, continue for 4 to 7 days. So taper in 7 days. But if it is not responding, then along with natamycin, we will add 1% voriconazole, which is a new antifungal. Voriconazole can be added, right? Or you can also go for 0.15% of amphotericin B. So either I am adding amphotericin B here or I am adding voriconazole. Especially for candida infections, voriconazole has to be added. The addition may be needed. And apart from natamycin, if any other option, it can be econazole. So another option could be I can start with econazole 1%. But if they ask you the drug of choice, our answer has to be natamycin 5%. Please, let's be very clear about this. Right? So that was about the treatment. Start with natamycin. If it is responding, taper it off in 7 days. If it's not responding, add voriconazole or amphotericin B. Simple? Chalo. Iske alawa, do we have to go for any other modality apart from topical drugs? Yeah, if it is a severe case, in severe cases, I can even give systemically, right? So systemic can be one option. When I give systemic, we all know about oral fluconazole, right? So you can go for fluconazole tablets. They can be given systemically, right? We can also go for voriconazole. Just remember, when you're giving these drugs, you have to monitor the LFT. Let's not forget that. You have to be alert about the LFT. What can be the other modality apart from systemic? You can give subconjunctival injection of fluconazole. If needed. And remember, fluconazole is most effective again against candida. And the third, if I have to give intracameral, which is inside the anterior chamber. Intracameral, intravitreal, not all antifungals are allowed. Which one are allowed has been your exam question. I think I've discussed in the first chapter, diseases of lens, when I'm talking about endophthalmitis, that antifungal which is allowed intravitreally is amphotericin B and voriconazole. Same here. Intracameral, I can either give voriconazole or I can go for amphotericin B. Okay? So that was about your treatment of the fungal keratitis. Now coming to one name, new name, that, one more thing, you can also learn this was your question. Silver sulfadiazine, which is used for the treatment of the burns, is also a treatment used as an antifungal. Okay, so you can use silver sulfadiazine for fungal keratitis. It is used as antifungal drug. Right, and in case of suppose a very, very severe type of fungal infection, recalcitrant fungal infection, then what we have to give here is one name, new name that you should know. The new drug is caspofungin. Just be familiar. I don't think they have ever asked you or will ask you, but we should always learn little extra, right? So just one name, caspofungin. Chalo, so that was about your, and of course, is this all we will give? Can we also not think of that if there is a uveitis along with this, so I will always give cycloplegics, right? I can think of that. If there is a lot of thinning of the cornea, then I am going to start with your tetracycline or doxycycline as well. Even that can help, right? So these things, and if it is too much thinning, you can even go for therapeutic keratoplasty. May be needed. Just to complete the list, it may be needed. That was about your fungal keratitis. I hope you realize how many Qs we have discussed. Next heading would be viral keratitis. So let's have a look. This was your fungal with a kerato. This is a dried up ulcer, and this is your, we will mark it as unsterile hypopion. It is unsterile hypopion. So look at this one. This is again with the projecting edge dried up ulcer, which is fungal, projecting ends. The projecting ends are even more clearer here. Right? So these are all hyphae. So these are all your, so these are all your fungal keratitis. This is how it looks like. Okay, so the next heading would be your viral keratitis. So talking about viral keratitis, of course, we have to talk about herpes infection, isn't it? So herpes infection is the most common infection, and it is considered in the cornea, that is in your viral infection causing keratitis. And this viral keratitis, first question let's solve is that which is more common? Is it herpes simplex or herpes zoster? These are the two main types. So we will first learn this only. Herpes simplex is much more common than herpes zoster ophthalmicus. So this infection of herpes zoster ophthalmicus is what we call shingles, isn't it? We also call it shingles. You should know this. Now, one more related to some community ophthalmology topic. One small question here. I'm not very sure they are going to focus on this or ask or not, but there's no harm knowing it. So write it down. This has been just mentioned in the recent edition. So let's know it. That the most common infectious cause of corneal blindness, but in developed countries. This is how they have said it is herpetic eye disease. So it is that common. Most common infectious cause of corneal blindness in it is mainly herpetic eye disease. Corneal blindness in developed countries, right? Okay, so once we know this, we all know that herpes can be simplex and zoster, I just mentioned. Coming to the simplex, a very quick revision, herpes simplex 1 is the infection which is above the waist, right? So this one is above waist infections. That means it will involve your face, lips, eyes, all this infection is HSV 1. Now, when you come to HSV 2, HSV 2 is mainly caused by, it is causing genital infection, so it is mainly below waist. Sometimes, as in case of neonatal ophthalmia, this can be the cause because it can lead to the infection due to vaginal delivery, right? So, in cases of neonatal conjunctivitis, you may note it down here in a bracket that neonatal conjunctivitis is mainly caused by HSV 2. So, that is one special thing. Otherwise, normally the eye infections are by HSV 1. Okay, so when you talk about HSV 1, it has a primary infection and recurrent infection. So, primary infection, this is self-limiting, it's a droplet infection. And just keep this in your mind that the severe corneal involvement is not a feature of primary. Primary infections which are self-limiting caused by droplet transmission are mainly causing blepharoconjunctivitis. So, primary infections are mainly causing blepharoconjunctivitis and very minimum corneal invasion, minimum corneal involvement. So, blepharoconjunctivitis causing minimum corneal involvement. So, this is your primary. Coming to secondary. When you come to the secondary infection, now this secondary, how does it, secondary, we call it recurrent, write it as recurrent infection. The second will be recurrent infection. So when you say recurrent infection, what is happening? Once there is a primary infection, it sleeps. The story is it is going to sleep into the trigeminal ganglion. And later on it reactivates there and it is manifesting with a severe corneal involvement. Okay. So it is generally dormant in the trigeminal ganglion most commonly, right? Sensory ganglion. And from the trigeminal ganglion, it is going to again cause infection, reactivation. This is the cause of recurrent infection. And here there will be severe corneal involvement. Okay, so that was a short story about your herpes simplex 1, 2, 1 is above waist, 2 is below waist, okay? And we are talking about what is primary infection in one and what is the recurrent infection. If it involves the cornea, now we come further that in recurrent infection when it is involving the cornea, what is the presentation? Yes, okay. So corneal involvement, of course, clinical features are going to be the same 5 fingers. So please remember, this is important. Okay, there's one exam question. Which is the pathognomic feature of viral keratitis? First, let's solve this one. Pathognomic feature of viral keratitis. You will answer, this is decreased corneal sensation. Okay, decreased corneal sensation. So both viral keratitis simplex and zoster, there is a decreased corneal sensation. Number 1. Apart from that, presenting features are what we have already learned. So what I want you to think? I want you all to think here, though the sensation is less, pain is still a feature. So pain, redness, photophobia, blepharospasm, discharge, blurred vision, everything is happening here. Okay. Then we come to on examination, what you are getting, we are going to learn layer wise. So if you make a section of the cornea, first involvement in the epithelium is superficial punctate keratitis, which is nothing but the inflammatory cells which are infiltrating the epithelial layer. This is SPK, superficial punctate keratitis. Infiltration of epithelial cells and inflammation in the epithelial layer. What next happens? Make the diagram along with me. What next happens is again a formation of ulcer, but this is linear ulcer. This is what is dendritic ulcer. Any linear ulcer has knobbed ends. Typical simplex ulcer will have, typical dendritic ulcer has knobbed ends, and these knobs are nothing but filled with virus. It has the virus. Okay? Please remember this. This is a repeated question. Dendritic ulcer is a feature of very common mistake from you all. You will just say both herpes simplex. It's only herpes simplex, not herpes zoster. Got it? And now what happens? Continuing further with the epithelial involvement, this can progress as number 3, amoeboid in shape. And if there is amoeboid shape ulcer, this is what is called GU. This is geographical ulcer. This is the reason steroids are totally contraindicated. Otherwise, any dendritic ulcer can lead to geographical, it can lead to perforation of the cornea. So steroids are contraindicated in dendritic ulcer. Very important question. Otherwise, it can lead to corneal perforation. Please remember that. Got it? Right. So what are the manifestations, epithelial manifestations in a viral keratitis? Now it's simple. It is SPK, it is GU, it is DU, and then GU. Easy? When you are looking at a typical dendritic ulcer, let me add here. The margins of the ulcer, this is the dendritic ulcer, the margins of the ulcer take the rose Bengal stain and the base of ulcer takes the fluorescein stain. So this is the denuded epithelium, and what is rose Bengal staining? Dead cells, mucus. So here what is happening is at the margin are virus laden dead cells. These virus laden dead cells are being stained by rose Bengal. Okay. So this is a typical dendritic ulcer. It's important, we needed this much of description. Right. So once we know this, we come to the next important point is your stromal keratitis. So next is your stromal keratitis. So if it is an epithelial ulcer, all of you, tell me one thing, in epithelial ulcer, how are we going to manage? What will be the treatment? So if it is an epithelial ulcer, epithelial involvement, because it's an ulcer, definitely no steroids. So many times we have just said. So if I talk about the treatment out here, we will start with topical. Let's first talk about investigations. Let's take all the 3 manifestations first. So that was epithelium. This will be easier this way. Second will be your stromal involvement. Let's first talk like this, not later. So stromal involvement, what do you think? How will it manifest? Remember, there are two ways. Either there is a direct infection. Any direct infection is leading to necrotic keratitis, or it could be just immune mediated hypersensitivity reaction in the stroma, right, leading to interstitial keratitis. Now comes the exam question, which hypersensitivity reaction? You are going to say type 3 hypersensitivity reaction. That was your stromal involvement. Okay. So necrotic keratitis, how will it present? Keep in mind there is going to be necrosis, infiltration, edema, right? So you are going to get all this. Necrosis and infiltration. Just remember this. This is your stromal involvement. Correct? Okay. Then we talk about third is your endothelium. Yeah. So endothelial involvement. Tell me, what will happen if there is an endothelial involvement? Again, endothelial involvement is going to lead to, in two ways it will manifest. Majority of the time it can be a hypersensitivity reaction, or it could be actual infection of the endothelial cells. That means again both the things can be there. Anyway, there is an endothelitis, whatever it is, right? So there is endothelitis. Either it is due to, write down, direct infection we are learning, or generally majority of the time it is hypersensitivity reaction. Now when it is a hypersensitivity reaction, now what type of hypersensitivity is another exam question we are going to answer. It is type 4. How will this hypersensitivity reaction manifest? This endothelitis is seen to involve only the central endothelial cells, right, in a disc-shaped manner. So these central endothelial cells in the disc-shaped manner, and this is what is called your disciform keratitis. So when you see this is what is disciform keratitis, right? So what is disciform? It is endothelitis in a disc-shaped manner. That is why you are calling it disciform. So disciform keratitis with therefore involving only the central cornea, leading to corneal edema. Edema? Why? Yeah. Endothelium is not feeling well. What will happen to the cornea? What was the main function of endothelial cells? To keep the cornea in a dehydrated state. So any problem, it will lead to edema. Whenever endothelium is not feeling well, there is going to be edema. Central endothelial cells are involved, therefore you are getting central corneal edema. This is a manifestation, and this is what is called disciform keratitis. Okay. So once we know the manifestation, clinical features, now we talk about investigation. Investigation for virus infection, do we need it? Generally not. Majority of the time diagnosis is clinical. And its typical clinical feature, decreased corneal sensation, more than enough. Still, any virus, you all know, viral infection we can detect by PCR. Or you may even go for GIMSA staining. I am now adding in a little bit of microbiology here. That is, multinucleated giant cells may be appreciated. Okay, I will not go in too much detail here. Multinucleated giant cells may be appreciated. What about HIV serological tests? That won't be of any use in recurrent infections. It can be only of any role in primary. So, not of much use. This is your investigation. We come to the treatment part. How do you treat it? Topical therapy generally needed, right? So when I say topical therapy, I am going to give topical acyclovir. So one more thing, all of you. Acyclovir and tetracycline are two drugs which are only available in ointment form. Keep this in mind. If you want to note it down, you can note it down. Right? So this is only available in ointment form. So we are giving acyclovir ointment. Now this is a question, how much percentage of ointment? Your answer 3%. You know, there is a question of your exam where they have asked you the percentage of atropine. So please remember that is 1%. They have asked you the percentage of tetracycline for treatment of trachoma. Again it is 1%. Right? So this one is 3%. Again I am telling you tetracycline atropine 1%. Yaad rakho. Right? Okay. So 3% acyclovir is given 5 times a day. Apart from that, in topical, what other options? So I am talking about topical first. So topical may first is your acyclovir, and the second we can go for is ganciclovir. So 0.15% ganciclovir gel can also be given. Ganciclovir gel is again given 5 times a day. Any other antiviral I can use? I can use trifluridine. Trifluridine. Again, the frequency starts from 9 times to 5 times, whatever. Now, next, other antivirals, but now they are older ones. They can be resistant against them, but you should know them. Idoxuridine. Idoxuridine. One more, know the name is Vidarabine. But these are considered little less effective. Okay. Then we talk about, is there any role of topical steroids? Not in epithelial ulcers, epithelial involvement. So if epithelium is healed and not involved, and there is no involvement, then I may give to control inflammation topical steroids, but under antiviral cover. I hope you all are clear what is antiviral, what is a cover. Cover means if this is the time duration I am starting and finishing the antiviral, then my steroid is somewhere here starting and finishing, isn't it? So it's under the cover, antiviral cover. So, but only if suppose there is a hypersensitivity reaction in the stroma or hyper. So this is only mainly for hypersensitivity reactions of stroma or endothelium. Then only there is a role of steroid, not otherwise. Direct infections, again, no, generally we will avoid it. So for hypersensitivity reactions of stroma and endothelium, I may go for some topical steroids for the control of inflammation. Okay, apart from that, can I think anything else topically that I have to give? If there is any associated uveitis, that I may have to give a cycloplegic, right? And of course, if IOP is raised, which is a chance, so IOP control is very important if raised, right? Now, a very interesting point I am telling you here, when you are controlling the IOP, avoid prostaglandin analogs because that actually promotes the activity of herpes virus. Okay, so avoid PG analogs in case of managing IOP in case of herpetic disease. Write down, it promotes herpetic activity. Okay, then we talk about, is, what about after topical, what about the systemic antivirals, or we are saying oral antivirals. So for systemic antiviral, learn like this, it will depend. That means I give oral acyclovir, but depends whether I want to give a therapeutic dose of acyclovir, oral acyclovir. This is given in both stromal keratitis, especially if I know direct infection, or endothelial involvement, right? Again, in both these cases, it's better to go for therapeutic dose. But if it is an epithelial involvement, we may just, topical is enough, and we may just go for a prophylactic dose of acyclovir. Okay, so then we go prophylactic dose of oral acyclovir. Now, what is the difference between the two? Therapeutic, I am giving 400 milligram tablet 5 times a day. Very simple. And prophylactic, why do you want to give prophylactic? Because it avoids recurrence of the infection. So, we give prophylactic in epithelial involvement, but in any other layer involvement, go for therapeutic dosing. Okay, what was the prophylactic dosing? It is 400 milligram again, but this time only BD. Okay, 2 times a day. Then it becomes a prophylactic. So, I have simplified this for you, how to learn the management of viral keratitis. Instead of the acyclovir, the other option can be valcyclovir. Okay, so if I am using valcyclovir, then prophylactic valcyclovir would be, I don't think they will ask you this, right? I am just giving you for the sake of it, just remember 500 milligram OD. If it is prophylaxis, again it is 500 milligram OD of this. Only learn the dosing of acyclovir, that is more than enough. We have many things to learn. Okay, we come to the next Before I move on from viral keratitis, one very important thing is, what are the causes of decreased corneal sensation? What are the causes of decreased corneal sensation? So apart from your viral keratitis, the next could be leprosy, of course, diabetes. Then can you think of something else? Any chronic degenerative condition of the cornea, like suppose we talk about band-shaped keratopathy, or even absolute glaucoma, or phthisis bulbi, shrinkage of the eyeball. All these cases, you see that corneal sensations are reduced. Or lastly, you can even note down number 7, section of the trigeminal nerve, section of fifth nerve. There will be loss of corneal sensation, isn't it? And we have talked about neuroparalytic and neurotropic, don't forget that. Whenever there is a sensation loss, what type of keratitis it will be? Leading to neurotropic keratitis, correct? Yeah. When the fifth nerve is involved. Okay, when we talk about next is your zoster, right? So this was simplex. Coming to the zoster. So everybody knows about varicella zoster virus. Varicella zoster, a quick revision here, all of you. Varicella zoster can be of two types. One is your varicella is causing your, remember, chicken pox, right? The infection causes chicken pox. And this is herpes zoster. And herpes zoster is what is called, I just told you, shingles. Now, let us learn about herpes zoster ophthalmicus. There are three main features here. Herpes zoster ophthalmicus, either there is a skin lesion, skin involvement, eye involvement, and trigeminal neuralgia. So everybody knows that it is following a dermatome of the ophthalmic division of the trigeminal nerve, isn't it? So that is supplied by that dermatome which is supplied by this nerve is being affected by zoster. Now, first important thing, what is Hutchinson's rule? This is an important exam question. Hutchinson's rule says that if the tip of nose is involved, in skin lesion, then eye will be involved. And why it is a rule? Because it is indicating the involvement of nasociliary nerve, right? Everybody knows now. Nasociliary will be again a branch of ophthalmic division of trigeminal. And whenever there are vesicles on the nose, I am giving you another interesting term. Vesicles are present on the nose, and this is the skin lesion is on nose. This is called Hutchinson's sign. Okay, so one is Hutchinson's rule, one is Hutchinson's sign. Okay. Now, generally, these patients, zoster infection you are going to get in immunocompromised patients, right? Remember that it is mainly immunocompromised patients. Elderly patients within R1, that is between 6 to 7 decades, and it is sometimes even an early indicator of HIV because it is seen in immunosuppressive. Shingles can be, just note down, shingles can be an early indicator of HIV. Okay, so once we know this, we already know the components. Now we come to the eye involvement. Ocular features you can learn as manifested in three forms. One is your acute eye involvement, acute infection. Second can be chronic eye disease. And third is your recurrent infection. Right? First we talk about is acute infection. When you say acute infection, what are the involvements in case of zoster? Again, let us make for the corneal involvement, we can make the section and learn. Epithelium, it is going to lead to, again the same superficial punctate keratitis. And this time you do not get a typical dendritic ulcer. What you get is pseudodendrites, which are smaller forms of the ulcer, and they don't have knob ends. So they are called pseudodendrites, or sometimes we call them microdendrites. So pseudodendrites or microdendrites. What is the next involvement? This is the epithelial involvements. Second, coming to stromal, just below the epithelium there can be coin-shaped lesions. This is the exam question. It is called nummular keratitis. Nummular keratitis is again nothing but subepithelial infiltrates. They are just infiltrations. And it can also manifest as a hypersensitivity reaction as interstitial keratitis. Coming to endothelial involvement, just like HSV, it is going to lead to disciform keratitis, disc-shaped involvement of the endothelium. So disc-shaped endothelitis is what is disciform keratitis. Disciform keratitis leading to central corneal edema. Simple? So diagrams always makes life simple. So just learn in this style. The way I teach you is, it is more simple if you make more diagrams on your copy. So ये वाला मेरा style, just try to follow it. It helps in a very quick revision also. If you have made all the cues and all the diagrams, when you're literally revising in the last moment, you can grasp all the points. Revise all the points, right? Then what are the other features? Of course, every keratitis is treated with uveitis, so we can mention that. And what is very important here, we will make a diagram again to learn the other features. Other features in zoster could be very important as uveitis, right? Then there can be episcleritis and scleritis in severe inflammations. Now, very, very important, of course, blepharoconjunctivitis, just like simplex. So there can be, which conjunctivitis? Follicular, isn't it? So lid involvement and conjunctival involvement is definitely a possibility. And very important, this is uveitis. And very important, we will not forget retinal involvement. It causes acute retinal necrosis. Okay, ARN stands for acute retinal necrosis. Coming to the nerves involvement, not the optic nerve, mainly we have to learn that it causes cranial nerve palsies. This is important, pay attention. It causes cranial nerve palsies. Which are the nerves which are involved? We will answer 3, 4 and 6. All the 3 motors. Most commonly involved is the third nerve. If the question says that which is the most common nerve involved in zoster, most common nerve in zoster, then we will not answer third nerve. So that is most common cranial nerve. Otherwise, most common nerve involved, if this is asked, they are asking you, you will answer frontal nerve. Okay? Yeah. Now we talk about is, of course, that was your acute. Coming to chronic eye disease. Chronic eye disease, what we will learn here, features, it can lead to, again, one part can be neurokeratitis. Very, very important is mucus plaque keratitis. This is one important. Chronic may you can get mucus, so you can get a mucus plaque. If there is a mucus plaque, how do you manage mucus? Acetylcysteine eye drops, right? Yeah. It will stain with rose bengal. Mucus stains with rose bengal and treatment will be acetylcysteine eye drops. Okay. And another thing that we will learn, it can also be chronic eye disease. Scleritis can be a part of chronic eye disease. So these 3, neurokeratitis, mucus plaque keratitis and scleritis. And of course, one more is lipid keratopathy or lipid degenerations. So you may get lipid. So lipid keratopathy is irregular deposition of lipid on the cornea. Just understand this way, very simple. It can either be idiopathic, then we call it primary. I'm going to take it in further also. So just listen here. And if it is secondary, it means that we know the cause. What did I say? Lipid keratopathy kya hai? Irregular deposition of lipid on the cornea. I said it is primary when it is idiopathic. It is secondary, we know the cause. And most common cause of secondary lipid keratopathy is what they will ask you, have asked you earlier, and answer would be herpes. It could be simplex also, zoster also, right? Come to the third one, that was relapsing eye disease, recurrent means relapsing eye disease. So the third is your relapsing eye disease, means now the reactivation is happening after several years. So that, did we write? Yeah, please correct this, it should not be recurrent, we will term it as relapsing. So relapsing eye disease means now the reactivation is after several years. Right? Okay, so once we know this, investigation same applied as we learned for simplex. Okay, we may not generally need it, otherwise we can go for PCR, same points. Then coming to the treatment part, of course topical treatment, whatever drugs you have learned for the simplex is again the same, and for the systemic, pay attention, this time this oral cyclovir is given 800 milligrams 5 times a day. Or if you want to give valcyclovir, what is the therapeutic dose? We learned the prophylactic dose as 500 milligrams OD, you remember? So therapeutic becomes 1000 milligram 3 times a day, or sometimes even given BD, but generally TDS. So we will learn 1 gram or 1000 milligrams TDS. So only 3 times a day, not 5 times. Now, what should be the duration of all these antiviral therapy? Whether I am talking about simplex or I am talking about zoster, it should not exceed 14 days. So generally we give for 7 days, 7 to 10 days, all this therapy, but should not exceed 14 days. Write it down. Maximum, even if I want to give, it should not exceed 14 days. If it exceeds more than 14 days, what will happen? So what will happen if it exceeds more than 14 days? You may see that the ulcer is still not healing and patient is just confused. What is happening? Why is this drug not affecting I don't think this is working. But actually what has happened is the ulcer is not healing because of toxicity of the drug. So this situation or condition is what we called, this is again very important for you all, metaherpetic keratitis. So what is metaherpetic keratitis? Ulcer is not healing due to toxicity of antivirals. You are over treating this patient with these drugs, or the patient is putting himself in, okay, let me, doctor has said for 14 days, let me put it for a month. I am going to be permanently fine. I will never get an infection. Will that happen? No. So he will develop toxicity towards the drug, which is called metaherpetic. Again, this is nothing but presentation will be that the ulcer still persists, and therefore the symptoms are all there, pain, redness, everything. So how will you manage it? Stop the antivirals and start with lubricating eye drops. Stop antivirals and start with lubricating eye drops. This will help to heal the epithelium. Start with lubricating eye drops. This will help to heal the epithelium. Right? So that was all about viral keratitis. Let's have a look at the slides here. So this is what you're looking at is superficial punctate keratitis. Okay, why do you call it punctate? It's all dot 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 type of presentation. It's all involving the epithelial layer. Again, it is the same superficial punctate keratitis. It has all been stained by fluorescein. What do you see here? We see a dendritic ulcer, and if you see, the ends are all round. So it's a typical dendritic ulcer. Have a look of little more. Here again, it is staining with fluorescein here. These are all typical dendritic ulcer. It is linear ulcer. Now what is this? It has taken an amoeboid shape. This is what is called geographical ulcer. So this is your geographical ulcer. Okay, and what are you looking out here? These are the skin lesions of zoster, which is not crossing the midline, and it is in distribution of the trigeminal nerve of ophthalmic division. What about this one? This is what, can you see this is also dendritic? Does it have knob ends? No. So it's a pseudodendrite. So we have to be careful and look for knob ends in order to know whether it is dendritic ulcer or not. So these are pseudodendrites. And what do you look here? Coin-shaped lesions in the stroma. This is what is nummular keratitis. I told you this has been your exam question, okay? So nummular keratitis, seen in stromal involvement of shingles, zoster. The next heading that we are going to learn is acanthamoeba keratitis. Acanthamoeba keratitis. So what is acanthamoeba? It's a free-living protozoa. It is ubiquitous, present everywhere, right? And it feeds on fungi and bacteria. So this protozoal infection, this free-living protozoa normally is not infecting your cornea. So this is a very rare infection. First very important point. and it only happens in contact. Which contact lens? Generally soft contact lens users washing their lenses with tap water, or you are swimming with your lenses on and no goggles, with contact lens without swimming goggles. Now you're exposing yourself to acanthamoeba. This is at a risk of acanthamoeba keratitis, getting acanthamoeba keratitis. Got it, all of you? Put a double Q here. This is a very important question. So if I ask you, which is the most common infection after soft contact lens use? Don't answer acanthamoeba. I just told you it's rare. If they ask you most common infection after contact lens use or after soft contact, because soft contact lenses are mainly prone for infection. If they ask you like this, most common infection after contact lens use will be, we have learnt it, Pseudomonas. But if they ask you, soft contact lens users are prone to develop which infection? So now they are asking, the intention of question is very different. Here we can answer acanthamoeba keratitis. So just be alert what they want to know, right? Okay. So once we know this, how will this patient present? Same 5 features. But what is very important, 2 points that are very important to know. Pain is disproportionately much more. We get pain, redness, photophobia, blepharospasm, discharge, diminution of vision, everything. But pain is disproportionately much more. Why? Because of perineural invasion. So this is a pathognomic feature of this infection is radial perineuritis. What you get is it involves the nerves, and because of this radial perineuritis, the pain is too much. On examination, let's make a diagram. We get typical ring lesion of acanthamoeba. What you get is a ring lesion. We may also get some pseudodendrites. This can be another presentation of acanthamoeba. So ring lesion, and this ring lesion is again, of course, it can be in form of just a ring lesion infiltration and it can become an abscess. And there can be pseudodendrites. Limbitis is another feature. So there can be limbal involvement or limbitis with stromal edema and infiltration. So these are some important manifestations of acanthamoeba. Limbitis with diffuse or focal stromal infiltration. Most common that you have to learn and ask in the exam is your ring lesion. I'll just show you. Correct. So once we know this, we come to investigation. Investigation, of course, first is your microscopic investigation, staining and culture we have to discuss. Second, we can even do a PCR for acanthamoeba, and you can directly look in confocal microscopy. And what you see here is bright spot double walled cysts. Anyway, so either confocal microscopy or PCR, but main important is staining and culture. At your level, this is where the questions are going to be asked. So what they have asked you for staining, which are the stains I can use? I told you, na, calcofluor white. One is calcofluor white. Very important. You can also know periodic acid shift, PAS can be used. One more, acridine orange, just know it, acridine orange, or Ginsa stain, gram stain. Even this is used. What we'll remember, what is asked in the exam already is calcofluor white. Talking about the culture, so culture is a double Q, repeated question about culture media. We will answer, what is the culture media? Non-nutrient agar with E. coli. Non-nutrient agar with E. coli. So E. coli is, trophozoites generally feed on E. coli. So two forms of the protozoa, one is cystic form and one is active, that is trophozoite form. So, non-nutrient agar with E. coli is a repeated question. Please remember. That was about investigation. We come to the treatment part. Now, first important group of drug. This is also a drug of choice. They have asked you is PHMB. PHMB, the short form was given in the option, so you should know the short form. PHMB. So PHMB stands for polyhexamethylene bigonide. So we will learn polyhexamethylene bigonide. Right? Okay. So that is one thing. You may even to this drug, it is apart from giving this eye drops, so it will be in eye drop form 1 hourly. You can also add chlorhexidine. Again 1 hourly eye drop. So that is one modality of treatment, but if they ask you the choice, you can answer very safely PHMB. What is the second is propamidine isethionate. So write down these are all diamidines. And the name that we will learn in diamidines is propamidine isethionate. Then the third group that you will know is we can also use neomycin. The limitation here is it is only acting on trophozoites. But of course, this is also modality of treatment, right? And what was the newer antifungal that we talked about? Even sometimes that is effective against this is voriconazole. Azole group of drugs, antifungals may also act against acanthamoeba. I think this will cause us confusion. Let's learn only these three. This is enough, right? Okay. And of course, if you have to control the pain because it's a very painful condition, so for pain, I am going to go for the non-steroidal anti-inflammatory drugs. Very rarely, steroids are generally avoided. Very, very rarely you may give in the cover, but let's not write it again. This much is enough. Okay. Anything which is done very rarely should not be noted also. Okay. So this is your lesion and this is the ring lesion we are talking about. Ring lesion of acanthamoeba keratitis. Okay. And again, this is the ring lesion with the abscess formation. Okay, so let's talk about interstitial keratitis. When we say interstitial keratitis, it means only stromal keratitis. Okay? It's a only stromal keratitis. Make the diagram. We'll draw something here. That means epithelium normal, endothelium normal. Okay, first let us write the different etiologies where you can get an interstitial keratitis. We can divide the etiology into syphilitic or non-syphilitic. Okay, syphilitic or non-syphilitic. So syphilitic, of course, most commonly it is congenital syphilis. Now acquired few cases, but generally most commonly congenital syphilis where the infection is transplacental. Talking about non-syphilitic causes, again the granulomatous inflammations like leprosy, tuberculosis, sarcoidosis, right? Then we have just learnt just now about herpetic eye disease that both HSV as well as HZO can cause this. Then we have also talked about that acanthamoeba may present as interstitial keratitis. If not, learn here. Then onchocerciasis is another cause. And lastly, let us learn this autoimmune disease, which is an autoimmune vasculitis, which is called Cogan syndrome. What is Cogan syndrome? Cogan syndrome is interstitial keratitis with deafness, sensory neural deafness. Right? So, interstitial keratitis with sensory neural deafness. There is also, so it's mainly a vestibular auditory dysfunction where you can also get tinnitus, we will get vertigo and so on. So this is what is called Cogan syndrome. And do you all remember what is retinitis pigmentosa with deafness known as? RP with deafness. Just at this point you will learn it. We are going to talk a lot of detail about this in the fundus chapter. So RP with deafness is what is called Usher's syndrome. This is the most common systemic association of retinitis pigmentosa. Anyway, coming back to the interstitial keratitis, so these are the causes, right? And I was talking about, back to the diagram. What do we have to draw here? So, in particular in syphilis, but it can be seen in other conditions, due to inflammation in the stroma, there is neovascularization and bleeding. This pink patch of bleeding that you see here, this is what is called salmon patch. So your exam question, salmon patch is a feature of, so first of all your first answer is for syphilis. So you can see the patch of bleeding, and later we can also see the ghost vessels. When there is no blood in the vessels, these are ghost vessels. So that is a typical finding of stromal keratitis, right? So all these, this interstitial, majority of the interstitial keratitis is immune mediated. Whatever the causes you have learned, it is all immune mediated. This is the reason when we talk about treatment, when we are talking about treatment, because majority are immune mediated, our main treatment is topical steroids, right? And sometimes, especially in COGANs, we may have to give systemic steroids and immunosuppressive drugs. May need systemic steroids and immunosuppressive drugs. Written? Okay. And because the stroma is involved, uveitis can be, so you can also please add on, there is also a role of topical cycloplegics. And can we also note down here that systemic penicillin has no role in interstitial keratitis. Okay, so even if it is syphilitic, we are giving steroids. So let us note this point down, that systemic penicillin, no role in syphilitic keratitis. Syphilitic interstitial keratitis. Done? Okay, so if we are talking about syphilis, what can be, just through one diagram, let me teach you what are the ocular features of syphilis. Ocular features of syphilis. So let's draw together. Okay, so again, whenever we learn the ocular feature, remember my tip, we have to start thinking outside to in, right? So the first important manifestation is interstitial keratitis. Then talking about, it can lead to uveitis, which is generally a granulomatous, majority of the time granulomatous anterior uveitis, though it can be either combination. Anterior, and of course it is when it involves the posterior part. So okay, let's go from anterior to posterior. So granulomatous anterior uveitis. Then let us come to the pupil and note down here about Argyll-Robertson pupil. We have learned this in neuro-ophtha, Argyll-Robertson pupil. Okay, what else you can get? Of course, we can get cataract due to syphilis. And this one we have learned, when it is involving the posterior uvea, the diffuse chorioretinitis that it causes is what is you call salt and pepper fundus. Most common cause of salt and pepper fundus, if they ask you, it is syphilis. Most common cause is syphilis. What is salt and pepper? I had explained you earlier also. Dispersion of pigment as if the look is like a salt and pepper, right? So why it is happening? It is a diffuse chorioretinitis. When you say chorioretinitis, it means what? Posterior uveitis. We are talking about posterior uveitis. And of course, it can also lead to optic neuropathy. Just a rough idea about what the syphilis can actually cause, what are the ocular features, and what it can lead to in the eye. Okay? Right. So after interstitial keratitis, let's see the slides. So this is a case of interstitial where only stroma is involved. Okay? So this is a case of interstitial keratitis. What do you see here? We see salmon patch. And along with the salmon patch, this is all stromal edema around it that you can see, and the stromal involvement and keratitis. Right. Next heading that we will give is keratoconus. Let's talk about keratoconus. So what is keratoconus? You all know it means conical protrusion of the cornea. So how do you generally, how are we going to define it? So it is an ectatic condition of the ectatic dystrophy of cornea. Note down please, it's an ectatic dystrophy of cornea leading to its conical protrusion. Right? Is it a genetic disease? Yes, genetic disease, slowly progressive. And what is the mode of inheritance? We will learn it as autosomal dominant. Slowly progressive means if this is the ectasia, it will slowly, it can, in majority of the cases, it becomes a progressive type. So it may be non-progressive, but generally the nature of diseases, it is slowly progressive. Okay. So this keratoconus. So when you talk about keratoconus, what is it leading to? Why it is troubling us? Let's see. If this is the cornea and this is the conical protrusion. So when the curvature is more, what happens? More the curvature, more is the refractive power. We have read this. Now imagine a case where the whole cornea is protruded like this. This situation is called keratoglobus. Right? So if there is a keratoglobus, what is the main problem in the patient? Myopia, because more curvature, more power is myopia. But when we say keratoconus, it is not only myopia, but it is also making this surface irregular. Isn't it? So this is myopia with irregular astigmatism. Myopia with irregular astigmatism. Irregular word is very important. If you say only astigmatism, it's not correct. You have to say irregular astigmatism. Okay? So myopia with irregular astigmatism. Now, because of this problem, once you know understood that this is the main issue in the eye, what will the patient complain of? Number one, diminution of vision. Secondly, because of, if it's generally progressive, there will be in young patients frequent change of glasses, especially in young patients. Bar again and again the number is changing. So frequent change of glasses. We are a little doubtful and we want to do a pentacam to know what is the situation, right? And if sometimes the astigmatism is very high, in high astigmatism, you can even get a uniocular diplopia, looking double through even one eye. We'll talk about it in the squint chapter. You note down, it can lead to uniocular diplopia. So these are the problems the patient is going to face. Now, when I examine, what do I see? Now, there's an interesting list of findings, right? So, let us try to concentrate on what are the findings of which I see. First of all, this you have learned with me, so I am going to mention it first, is Fleischer's ring. How do you see a Fleischer's ring? You remember what it was? Iron deposition, which is seen at the base of the cone, right? In the epithelium, right? This iron deposition, which is seen in the epithelial layer, is what is called Fleischer's ring. We are going to see through slit lamp. Okay. We come to the next finding. When this patient is looking down, you will see that his lower lid is also pushed down in a V-shaped manner. This is called Munson's sign. Write it down, then I am going to show you this. It is V-shaped deformity of lower lid on down gaze. V-shaped deformity of lower lid on down gaze. Right? Have a look. So this is a keratoconus. Most commonly, this conical protrusion is going to be inferotemporal. Remember this, it is inferotemporal. See, when this patient is looking down, what is happening? The lower lid is all deformed. So this V-shaped deformity of the lower lid on down gaze. Deformity on down gaze. This is what is called Munson's sign. Written, again this will be seen on what? Torchlight, common sense. This is a torchlight examination finding. What is the next thing that you can see? We were talking about Fleischer's ring. Have a look. This is a slit lamp finding. We are seeing through cobalt filter. That's why the blue light. This ring, this is what is Fleischer's ring, as you can see here. Right? So, Fleischer's ring is iron deposition. What next finding that you can get here? Let's see here. What do we have in store? What is this? Again, can you see it? Appreciate it's an oil droplet form. This is what is called, I've taught you all the oils if you remember. Hope you have first covered the first chapter, disease of lens. So right on, next we will learn is oil droplet reflex. This one is reflex. We learned about cataract and galactosemia. We learned about globule reflex in anterior lenticonus, if you remember. Now we are saying oil droplet reflex. Of course, the clinical picture seems same. Therefore, what is the diagnosis is held only through other clinical findings. So, oil droplet reflex is seen on distant direct ophthalmoscopy. This dark reflex just at the base of the cone that we are able to appreciate. So, you have to understand it is through distant direct ophthalmoscopy that we are seeing the oil droplet reflex. Okay. What is the next finding I can see? The next finding that we can see here is prominent. Okay, before I go to the prominent, what about in retinoscopy? If I do a retinoscopy, what is retinoscopy? Objective method of refraction. When I see the reflex, normally what happens? You see a reflex at the vertical axis and one belonging to horizontal. Now in this patient, the cornea is so irregular that the reflex looks like a cross and it moves a little bit like this and it looks like two blades of a scissor. That's why you call it scissors reflex. You'll understand it more once you attend the optics chapter where we have discussed in detail. We will be discussing the retinoscopy process. Okay, so retinoscopy mein what do you get? Scissors reflex. Just remember this. Okay, then what do? You want to do a corneal topography? What will be the finding in a corneal topography or tomography to be exact? Which is because the best is go for pentacam. I explained you. So what do you see? Initially, this protrusion may be leading to initially when there is a regular astigmatism. If you remember, in regular astigmatism, in very initial stages, I will get a bow tie appearance. But soon this is going to lead to asymmetrical appearance because of irregular astigmatism, right? And so this is going to progress as, so this is what we are going to see in a tomography or topography is irregular astigmatism, right? Just remember that. Because of irregular astigmatism, we see asymmetrical appearance. Of course, what is the choice, investigation of choice? It has to be pentacam, please. Okay, always answer this. That is corneal tomography to be very, very accurate. Where you are getting a 3D image of both anterior and posterior surface so that we are able to see the early changes of the posterior surface. And also, you know, when there is an early changes, very early change of keratoconus, no clinical signs are seen in the slit lamp, but still there are changes, abnormal topographic finding. What is that called? Form fruste keratoconus. Okay, so this is just early, very early case which can be caught only on topography or tomography, looking at the posterior surface of the cornea, but the slit lamp findings and the signs that you have just discussed with me, they are not present. Okay, that is called form fruste keratoconus. Okay, so this is your, any other finding we have to list it out? This was corneal topography. Any other finding we want to list out? Yes. On excessive stretching, there will be break in the inelastic membrane, which is the Descemet's membrane. So any break looks like vertical stria here. This is what is called Vogt stria. You remember you learned in congenital glaucoma, the stria were looking something like this, horizontal or circular. These are Hab stria. So the difference is, this is parallel to the steep axis, so it's a Vogt stria. This is seen in, again in keratoconus. And lastly, prominent corneal nerves. Now this is again very important. Why are the nerves prominent? Prominency is not due to thickening of nerves, it is due to thinning of cornea, and this has been your exam question. So you have to be clear that this is due to thinning of the cornea, right? Not thickening of nerves. Let's have a look. So this one is your oil droplet reflex of keratoconus, which is seen on the distant direct ophthalmoscopy. Look at this. These are the vertical, that is a Vogt stria. Look at this. This is the prominent corneal nerve, right? Prominent corneal nerves due to thinning of the cornea in this case. Again, look at this one. These are also prominent corneal nerves. Can you see the corneal section? And very clearly it is shown prominent corneal nerves. So these are the findings. Now before we move further, what are the causes of thickening of the corneal nerves? Thickening of corneal nerves. First, of course, let's note down leprosy. Second, write down neurofibromatosis type 1. Sometimes it can also be seen as a process of old age. And interstitial keratitis and Cogan's syndrome may manifest with thickened corneal nerves. So what I want you to learn very nicely is 1 and 2, leprosy and NF1. It is leprosy and NF1. That is very important. You all should be able to answer this. Thickening of corneal nerves, leprosy and NF1. Right? Okay, so these were the findings of keratoconus. Once we know this, next thing is, what is the treatment? So early cases when this protrusion is, the component of astigmatism is not much because the protrusion is less. So you may start with, of course, first and foremost, let's not forget to mention, avoid any eye rubbing. This will increase your protrusion. We can start with the spectacles or toric soft contact lens. So toric means it has cylindrical correction, it will correct the astigmatism. So you may start with this, but very soon it is not going to be effective. Why? Let's see this. Make the diagram. This is your keratoconus. What is the soft lens doing? It is taking the shape of the cornea itself. So the irregular surface is still irregular. But if I am replacing it with a rigid permeable, gas permeable lenses, semi-soft lenses, I am replacing this irregularity with a regular surface, isn't it? So what should be my choice of contact lens has been your exam question. We will answer RGP lenses. So rigid gas permeable lenses, right? This is the next line I would prefer. Now, if I realize here, okay, it is a progressive case, then I should opt for the next thing is C3R treatment. C3R stands for corneal collagen cross-linking with riboflavin. These are the 3 C's with riboflavin. What are you doing here? You are putting riboflavin eye drops for 30 minutes and then you are exposing the cornea to the UVA rays. And while you are exposing, you are continuing putting riboflavin eye drops while exposing to UVA rays. Right? So you are 30 minutes means every 3 to 5 minutes you are putting the eye drop for 30 minutes. It means this, not continuously for 30 minutes, but every around 3.5 to 4 minutes, or between 3 to 5 minutes, I am putting the eye drop, that is riboflavin. And then after that, once I have done this, this is the Dresden's criteria of C3R. Okay, so what is the Dresden's protocol? We are discussing this, that what we are doing here is we are putting the riboflavin for every 3 to 5 minutes for 30 minutes. And then we are exposing it to UVA rays for another 30 minutes. And while we are exposing, please keep in mind we are still putting the riboflavin. Now we don't have to go into too many details, SK variations and what else we can do. They are not asking at our level. Just remember this is the C3R treatment. And next what I can do? Another option for me is, especially if it is an eccentric or displaced cone. It's gone little displaced. So for displaced, an eccentric cone, eccentric conical protrusion or cone, we can use Intacs. Okay, what is this? These are nothing but intracorneal ring segments, corneal segments. Okay, so these are intracorneal ring segments which can be put to alter the curvature of the cornea. Right? So you have to create a channel, and inside that channel, which can be either created by laser or manually, and then you're putting these rings to alter the curvature. Right? So this is done when of course, the position is eccentric, and also another point, I will do it when it is non-progressive. I will not be able to do it when it is progressive. So you can learn it like this. Of course, after RGP, if it is progressive, I would prefer C3R in a progressive case. And if it is not, another situation, it is not progressive but eccentric cone, then I will prefer intacs. At your level, if they ever ask you the treatment of choice, it's safer to answer C3R. Okay, but intacs has also been recently asked in exam. You should know what is intacs. And after this, if nothing is working, replace the cornea by the healthy cornea, go for keratoplasty. When you say keratoplasty, because the whole cornea is involved, it is better to go for penetrating keratoplasty, where you are replacing full thickness. Or otherwise, we can even go for deep anterior lamellar keratoplasty. I'll just talk about these. But generally, we will go for penetrating should be the answer. Okay? Another important thing about keratoconus that we need to study is what are the associations of keratoconus, right? So associations can be systemic and ocular, right? Few things are important at double level also, so let's learn it. Associations of keratoconus. We are saying it can be either ocular or systemic. Can you think of any systemic association, keratoconus? Try to think with me wherever the collagen problem is there, right? So we have been talking about like Ehlers-Danlos syndrome, right? Osteogenesis imperfecta, okay? Then it can even be seen in excessive stretching of the eyeball and where you have learned about Marfan syndrome, where that is again a one cause. Generally, we get cornea plana in that, not keratoconus. I think we will leave Marfan's. It will create confusion. Let's learn Ehlers-Danlos. Correct this. Just learn Ehlers-Danlos, osteogenesis imperfecta, and very important Down syndrome. This much is enough. Overlapping information, let's discourage. Talking about ocular. Ocular, very important. Vernal keratoconjunctivitis. Make a nice cue. You should be remembering this. That vernal keratoconjunctivitis is associated with keratoconus. Can be due to excessive rubbing. Even atopic keratoconjunctivitis. AKC is atopic. I have discussed this in the conjunctiva chapter. Even excessive rubbing can lead to keratoconus. Right? And then of course all these, if you look at the systemic associations, it's easy to understand that blue sclera is one association of keratoconus due to the collagen problem. Right? And I think we will not increase the list, it will increase, just complicate the things. So this much is enough for the associations of keratoconus. At our level, this is more than enough if we know this much.